Okay, here we go. So we're going to get into part one of the concepts in primary care. And part one, we're going to focus on the family-centered theories and then take it from there in terms of genograms and applications to practice, harm reduction, and how to apply it. So let's begin. What is family and family-centered care theory? Family-centered care theory considers every patient in the family with equal dignity and respect, regardless of race, ethnicity, cultural background, that promotes the recognition of diversity and individual choices of the family and its members. So basically, you want to just be sensitive and embrace everybody in the family who's important to the patient so that you can really develop good rapport. Understanding the family as a patient versus the family as a population. Every family is different, right? Do we treat the family as a whole, or do we use family primarily as a description of the population we serve? You have to be very careful with that. Every family is different. So just be sensitive to the family union, the influences of the patient, the genetic disposition from within the family, the patient's preferences, behaviors, if they've lost anybody in their family, any kind of family turmoil that's going on, and sensitive to, how that's going to influence the patient's support system. And again, redefining of the family. So your family and my family might be very different. When I think about my family, my parents split when I was very young. They never actually got married, but they both my mother and father remarried. So I have step parents from basically that have been present my entire life, both a stepmother and a stepfather. But I do consider them part of my family. And, obviously genetically, they're not an influence, but, I do have half sisters from both of my step parents. So I have quite a diverse family. So just keep that in mind when you're talking to your patients. So in terms of understanding the family, another huge thing we want to really work on in primary care is thinking about genetics and genograms. And what is a genogram? A genogram is basically a description of like a specialized drawing that we create in practice that represents like the family tree of the patient. Basically, we try to focus on three generations out. And it goes beyond the traditional family tree, and it basically focuses on the child, the parents, and the grandparents and the great-grandparents. And as you can see in the legend in the right-hand corner in that red box, that's how you define, what each family member represents within the genogram. So you have people who are dead, they have an X in the box. Spouses would be male and female, with the square being male and the female being circle. And so on and so forth. And that's how they break it down. Now, when you do your assessments and your case studies, including in clinicals, you are going to be expected to create a genogram. So familiarize yourself with that legend, and then I would definitely get into your textbook and really focus in on how it is you would draw a genogram. And we'll get more into that as time goes on. We'll practice that throughout the class. But I do want you to familiarize yourself with what exactly a genogram is composed of. Okay? It allows us to really analyze the hereditary patterns of disease. So we really want to know, does diabetes run in the family? Heart disease? Was there sudden deaths at young age? Did we have a spouse die from any sort of car accident? Those kinds of things. We want to know what's going on in the family. Like, what were the sudden deaths caused by? Was it heart disease versus a car accident? That sort of thing. Okay, so family-centered theories. So these concepts evolved back in the mid-1900s, and it was really to kind of focus on by Carl Rogers, and he wanted to recognize that the family is a constant in a patient's life and their primary source of strength and support. And that's why we're so big as NPs, is trying to get involved with the family members to try to bring expertise to both the family member and the patient in terms of caregiving. Remember that family-centered care is focused on competency enhancing rather than weakness focused. So you don't want to focus on their deficits or their inability to do whatever it is you want them to do. You want to focus on the positive outcomes that the patient is accomplishing. And day-to-day positive moves towards a healthier situation is always better to focus on than, negative outcomes. But sometimes in disease processes, especially cancer, or any disease that causes, them to become debilitated, you always want to just focus on those positive moves that go towards a positive outcome as opposed to a negative one. And obviously, as an NP, one of your roles is to navigate that family-to-family support, the networking between other healthcare practitioners, and any financial needs that the family patient may have, to help support his, care plan. Applications to practice. Okay, so what we want to consider is how might an FNP incorporate concepts of family-centered theories, assessment, and treatment in a system that has become focused on treating the individual? What might that look like? When might it be useful to do a quick family genogram in primary care? And how might it benefit you and the patient? Okay, so in terms of incorporating concepts of family-centered theories, one of the easiest ways that you can incorporate that into your assessment and treatment is by doing a genogram. Or starting to just ask questions. It doesn't even have to go right into a genogram. It could just be asking the patient, tell me about your family. Are your parents still alive? Do you have any sisters and brothers? How about your grandparents? A lot of the times patients don't know, or they don't remember certain events in terms of their family health, any of their family's health issues or past things that they've had to deal with, but things that might jog their memories or any major life events, or do they know of any medications that their family members might be on? Do they take any vitamins? What is their health, situation within in the household or in the family look like? Are the majority of the people in the family obese? Like, these are things you kind of want to just start thinking about in terms of looking at the family as a whole, because it'll give you insight as to what the patient has been exposed to and what their life system and life practices are like. And that's when you do get into the family genogram and you have the patient help you. They may need to come back at another time or another visit with more information, but at least you open that door, because a lot of the times patients come in presenting with symptoms and you're kind of at a loss as to the severity of what those symptoms could be presenting. It could be something simple or it could be something much more complex. If you know what the patient's family has like what their family history has, through a genogram, you could definitely start to narrow down your differential diagnoses based on what their past history looks like. This would benefit you in terms of, really narrowing down what tests you need to order, what blood work you need to order, and it'll make it easier for the patient, because the patient will realize, if something that they're starting to show symptoms of their family member had, and their family member maybe didn't have such a good outcome, this might encourage the patient to make changes with the modifiable factors in their life that they can change. So these are the references for this particular presentation. And that's pretty much it in terms of that. I wanted to get into harm reduction now. So we want to emphasize, in terms of harm reduction, we're emphasizing public health, human rights, human harm reduction programs to provide essential health information and services while respecting individual dignity and autonomy. Okay, so what exactly is harm reduction? Harm reduction is a non-judgmental approach to care when healthcare practitioners meet patients where they are at. What does that mean? That means you go with the patient with the flow of where the patient is at. So if the patient, okay, let's say the patient is a big time smoker and you really are concerned about this patient, they consistently are coming in with upper respiratory tract infections, and you're really concerned that they're putting themselves at really high risk for cancer, but the patient themselves are not ready to even consider quitting, then you have to really take it down a notch. You have to provide them with the information that you know is important for them to be aware of, but don't hound them in terms of, wanting to quit. Or needing to quit. Like, obviously they're understanding the importance of it. You know, when I moved to Florida, one of the first things I noticed was people here smoke a lot. And, you know, I said to myself, what, did they not get the memo that, you know, smoking causes lung cancer? Of course they did. You know, that is a thing that, you know, is very well known in our society. But unfortunately, culturally here, it's normal for people to smoke. It's a very social thing that they just tend to smoke more here than I noticed that they did in New York. But, you know, you just kind of approach people where they're at and you reevaluate at every wellness visit and just keep trying to encourage, you know, if the patient says, you know what, today I'm going to only smoke 6 cigarettes instead of 7, great. Really try to just encourage that. Small wins are better than nothing, right? You know, the whole thing in terms of reducing harm is just really don't approach your patients with judgment or any kind of like talking down to them. You know, everybody has a right to their own health and the freedom to do whatever they want. That's part of our human rights. So just again, focus on positive change and improving the patient's health outcomes without judgment, discrimination, or requirements that the patient stop as a precondition to working with them. Okay. So the benefits of harm reduction, obviously things that we can do to help reduce harm are, you know, the benefits of that are lowering HIV risk and hepatitis transmission, preventing overdose, providing a gateway to drug treatment programs for drug users by offering information and assistance in a non-judgmental manner, protects the law enforcement officers from needle stick injuries by providing safe disposable injection equipment, and reducing the number of contaminated syringes circulating in the community. These are all harm reduction factors that were put into play by the NC Harm Reduction Coalition in 2021. You know, these get into like more intense ways of reducing harm. You know, before when we were talking about smoking, that's just starting with really basic stuff, but this goes into much more intense things in terms of, you know, really lowering HIV risk with these drug treatment programs and, you know, reducing contaminated syringes circulating in the community, which could obviously potentially contaminate somebody else. So these are all benefits of harm reduction. Again, the principles of harm reduction are really trying to approach people with non-judgmental approaches, like by treating them with dignity, compassion, respect. Do not stigmatize them by, you know, accusing them of having a substance abuse disorder, and just accepting the little behavioral changes they can as small gains. You know, sometimes people who are able to make positive gains offer actually a really big benefit for the community, because when people see other people finally able to, you know, overcome their abuse issues, and they're able to see that one person in the community could do it, it definitely has a ripple effect. So, you know, and one patient you're helping may actually be helping a lot of people. You don't even know what you're getting into sometimes. And like these, you know, there's definitely some evidence that people are much more likely to take multiple tiny steps rather than one or two big, huge steps. So just keep that in mind, baby steps to the finish line. We want to focus on quality of life improvements over abstinence. Sometimes that's the best thing you can hope for. You know, I mean, they may not be able to 100% quit, but at least they can get their life into order and they can try to be a little more productive within their life. You know, you always want to approach everything with evidence-based policy and practice. We've learned that in research. And we always want to focus on empowering the individuals as the primary agent responsible for reducing the harms related to their substance use. So giving the patient the option to make changes for themselves is very empowering. You know, sometimes people just need to hear, you have control over this, it's up to you. A lot of the harm reduction focus within this particular lecture is based around IV addicts, prostitutes or sex workers, morbidly obese patients, and active smokers. Okay, so in terms of active IV addicts, you want to assist them in getting access to clean syringes as opposed to getting off drugs immediately and completely. That might be a more attainable step. Working with sex workers, you want to assist in providing them access to birth control, STD testing, and treatment without judgment. That's the first step in helping them to make positive choices for themselves. A lot of people, a lot of patients who have these particular issues have extremely low self-esteem and low self-worth. So you really have to try to just offer them support at some level in the beginning to just try to get them to want to get help and help themselves. So in other populations, in terms of working with morbidly obese patients, you want to take incremental steps towards any lifestyle change while working towards the goal of obviously reduced weight and healthy lifestyle changes. Same thing with working with an active smoker. You want to praise them for incremental steps towards recovery in terms of cutting back as opposed to immediate cessation. Work with the patient to develop small goals and plan while actively smoking. So, some patients really work, a lot of patients actually probably work best with baby steps towards a bigger goal. But there are some patients who have enough wherewithal within themselves that like going cold turkey actually might work for them. You have to, again, really talk to your patient and see where they're at without judgment and sensitivity towards, their own needs. Okay, so consider, in terms of harm reduction, we want to consider how might a future FNP work with patients using harm reduction while being caring, professional, and presenting facts without shaming, taking small steps in mutually agreed treatment plans. What might that look like? Do you see any legal or ethical ramifications? So this is a really interesting question. I think that this is something you guys should consider within your own practice if you've ever had to approach a patient about any kind of behavior that you felt would benefit them if they changed. Consider, how you handled that particular situation. Is there any way you would have gone back differently in terms of presenting the information or talking to the patient about their particular issue? And in terms of legal ethical ramifications, the one thing I will tell you in terms of documentation, when you are talking to patients about behavioral changes, you always want to make sure that within your documentation, you are clearly stating that you educated the patient on whatever particular subject matter it was, if you provided them with any resources. You also want to talk about what their response was. Did they agree? Did they verbalize understanding? Were they interested at this time in starting a treatment plan? And if not, what their thought process is or where they're at. You want to document all of this just so it's very clear in the patient's records that you did bring it up, that you did present the facts, that you did attempt to get the patient to participate in the treatment plan and what their reaction was. And again, in follow-up visits within your primary care practice, you're going to reevaluate each time the patient comes in any of the behavioral things that you think might benefit them in terms of their healthcare plans. Okay, health promotion and disease prevention. All right, so the definition of this health is always evolving. Here we go. So is it an absence of disease? So what is health? Okay, the definition continues to evolve, but many view health as the absence of disease. Although the problem with this view, it does not account for the multidimensional characteristics integral to a human being. I mean, the one thing you always want to keep in mind is that human beings are social, emotional, and spiritual beings. And that's the beauty of being a nurse practitioner and really looking at the patient from a holistic point of view. In 1948, the World Health Organization defined health as a state of complete physical, mental, and social well-being. However, this does not account for the spiritual dimension of a person. So as you see in this diagram here, we encompass, as a nurse practitioner, we encompass all dimensions of the human being, the physical, the social, cultural, the psychological, and the spiritual piece to health. So a patient may be physically healthy, but the spiritual, social, and psychological dimensions may not be balanced, and therefore the patient is truly not healthy. We cannot really truly determine someone's health status without fully evaluating all these attributes. Okay, so health promotion can be defined as activities and preventative measures that contribute to an individual's state of optimal health. So FNPs, or family nurse practitioners, have an active critical role in educating the patient on health promoting education and activities, which include fitness, exercise, breast self-awareness, appropriate nutrition, relaxation, stress management, social support, prayer, meditation, excuse me, and other things like immunizations, mammograms, pap smears, colorectal cancer screening, and PSA screening. Remember that health promotion requires a commitment on the part of the individual patient and the healthcare provider and the community. We're all involved in health promotion, and we all have a partnership to achieve these goals that will enhance health and well-being. But remember that the health promotion really should begin with the clinician. You as an FNP have that role. And it's pivotal in our role in educating the patient and the community about the health promoting behaviors. And make sure you also educate your patient about how their environment can contribute to health or disease as well. Health promotion and primary prevention are best achieved through primary prevention strategies, which are activities to prevent disease and illness. When not possible, when primary prevention is not possible, secondary or tertiary are employed, which is the goal of optimal wellness. So the FNP uses evidence-based guidelines and standards to prescribe, promote appropriate age-based recommendations. And we use the primary, secondary, and tertiary levels of prevention to achieve those goals. Now, super important. There's the 3 levels of prevention. We have the primary prevention, which is the prevention of disease. We have secondary prevention, which is early screening and detection of the disease. And then we have tertiary prevention, the restoration of health after illness or disease has occurred. In the first half of the 20th century, most healthcare was focused on the belief that the time was that the patient should seek healthcare when they're ill. But as time has gone on, we've evolved, and now we have the tertiary level where we prevent further insult or injury after the disease has occurred by stabilizing the patient's condition to prevent further deterioration. And advancements in technology really contributed a lot to diagnostic testing, which is what's helped us shift the focus of healthcare to both the secondary and tertiary levels of prevention. Okay. All right, so with the focus on screening and early detection, treatment could be instituted before overt signs and symptoms appeared. So, for example, blood pressure would be checked in a patient with no symptoms of hypertension, and if elevated, a plan of treatment would be instituted. The goal was and is maintaining the patient's blood pressure within normal limits and minimizing the development of catastrophic complications, such as a stroke or myocardial infarction. All right, so make sure you really understand the levels of prevention. Again, primary prevention, we're preventing disease. So education is key is prevention in terms of primary, and it's all about education. Seatbelt use, violence prevention, fall risk education, exercise, healthy eating, smoking, cessation, avoiding alcohol and substances. Stress reduction is a big one. Eliminate allergen exposures and immunizations. Immunizations are one of the biggest things in primary prevention. Okay, keep that in mind. Big thing, immunizations. Key is prevention, right? Secondary prevention is screen for disease. So screening for hypertension, screening for cancer, mammograms, PSA, fecal occult in the blood, screening for lead, screening for TB. Remember, secondary, the key is screening. So primary is prevention, secondary is screening, and tertiary is treatment. That's how a key to remember these 3 different levels of care and interventions. So in tertiary, we're treating the disease. We're prescribing or recommending treatment to prevent further sequelae of the disease. We also want to include pharmacologic and non-pharmacologic interventions within tertiary. Okay, excellent. Okay, is this primary or tertiary? Okay, so Note, once you are intervening for a disease or actively treating what may have been considered a primary intervention could be a tertiary intervention. For example, in a healthy person, discussion of nutrition is primary. In a patient with hypertension, recommendation of low sodium or DASH diet is now tertiary, as you are now treating a disease, not preventing it. So do you understand that this patient has already been diagnosed? Now we have to change his diet in order to prevent the disease from getting worse. So we're now treating it, we're no longer preventing it. He already has the hypertension, it's a done deal. And here's another example. In a healthy person, educating on avoiding illicit substances is primary, because the patient is a healthy patient. He doesn't have a substance abuse issue. You're just talking about avoiding it to prevent any issues. That's where you're still in the primary intervention. But for an addict, education on quitting the addiction is now tertiary because they have already become addicted. So now we're not trying to prevent, we're actually trying to treat. We're trying to treat the addiction, not prevent it. All right, so that's the difference between primary versus tertiary education.
It's 4 o'clock.
How does the FNP know which primary, secondary, or tertiary interventions to use? Okay, learn which primary prevention, screening tests, and treatments for common disorders of each system and routine wellness. In practice, use current age-appropriate evidence-based guidelines, standards, and recommendations. Okay, so we will get into the government entities and talk about how important it is for you to know the appropriate screening tools and where to find which screening tools to use depending on the age process or the age of your patient. Okay, because there's different immunizations that need to be given at certain ages. There's different screening tools depending on the age of the patient that need to be done. And the recommendation guidelines are based on the Preventative Task Force and the World Health Organization, the CDC guidelines. All of them have their own guidelines as to when you should do what. And keep in mind, this is very important to know because it'll give you a basis when your patients are coming in for their wellness visits in primary care, as well as what the insurance is actually going to pay for, because the insurance will not do primary care screening, unless it's actually recommended by the governmental entity that puts out the guidelines, whether it be the CDC or the USPTF. So, and remember, these screening guidelines should be part of each visit and use all appropriate opportunities to promote health and wellness. Like I said, use the approved recommended guidelines and stay abreast of changes, which occur frequently with the endorsement of new research, because remember, everything we do is evidence-based practice, and every year things change based on new guidelines. Okay, adult health promotion and maintenance activities and screenings. There are standard recommendations on many health promoting and primary prevention activities such as mammograms, pap smears, prostate exams, testicular exams, and the PSA, cardiovascular lipid tests, blood pressure management, vascular exams, renal, weight, bone density, eye exams, and more. Certain chronic diseases like diabetes, cardiovascular disease determine which primary prevention and screening tests to order. These screening tests are aimed at preventing and reducing the burden of disease on the patient and the system. For example, recommendations for diabetics include specific screening for ocular disease. We all know we want our diabetics going to the ophthalmologist as well as the podiatrist, right? And then, recommendations dovetail with healthy people and US biostatistics data. For example, diabetic retinopathy, glaucoma, macular degeneration are all common in diabetics and leading causes of low vision and preventable blindness. Therefore, evidence-based recommendations are tailored to this particular population in terms of eye exams and what the insurance will cover in terms of preventative visits and screening visits, I should say. Okay, influences in health promotion. So we have individual influences, community influences, and the risk factors that are important to determine appropriate screening tests. So individual influences in health promotion would be just their own behaviors. Individual encounters with patients provide an opportunity to educate the patients about their individual risk factors and the changes they can make to prevent or at least delay the onset of diseases. So community influences, are important because the healthcare providers can be instrumental in developing healthcare promotion strategies within a community, which can be accomplished by developing interventions that include identifying community groups at risk for certain diseases and developing community-wide educational programs that will educate these groups about their potential risks. And then, of course, risk factors, important to determine appropriate screening tests. So, for example, you have maternal and familial history of breast cancer may determine at what age a mammogram starts. Also, strong family histories of early death from heart disease influences how you engage with a patient presenting with cardiac symptoms. Okay. The interesting thing about risk factors and health promotion that I want you to also know and keep in mind is it's, obviously identifying risk factors is an essential component of health promotion. However, some patients have no known risk factors where others have many. Sometimes there's no rhyme or reason to why patients get these certain diseases, or they may, I've had 90-year-old patients smoking their entire lives and never develop any issues with their respiratory system or lung cancer or anything. Why is that? I don't know. Obviously, they have much higher risk factor than somebody who doesn't smoke, but sometimes that is the case. It does happen. Keep in mind, not all diseases can be prevented, and not every person with an unhealthy lifestyle choices will get a particular disease, but the elimination or alteration of a certain risk factor can have a significant impact on disease outcomes. And this is where you need to be also very aware that some risk factors are modifiable where others are non-modifiable. Okay, so things that you need to consider in terms of ordering screening tests. These are important because you just don't want to be ordering excessive amounts of tests that are sometimes not covered or are very expensive. So does the condition significantly affect the quality and quantity of the patient's life? If you have a patient on hospice, are you going to be ordering a significant amount of screening tests? No, obviously not. But these are the kinds of things you really want to keep in mind. What is this particular test going to do for the patient? Is it going to tell us something that's going to dramatically alter the course of treatment, or is it just going to tell us what we already know and the patient has already made decisions as to what they plan on doing and not doing? Those are the kinds of things you want to know. Are there acceptable treatment options available? If the test gives you a certain information and the patient is not going to even bother with those treatment options, is it really worth doing the test? Okay. Does detection of condition while asymptomatic significantly reduce the morbidity and mortality if treated? Again, is this really going to make a difference in the patient's plan of care? Is it really going to help them, or just give us more anxiety and more questions? Does the treatment in asymptomatic phase yield a therapeutic result superior to that obtained by delaying treatment until symptoms appear? So sometimes they have something, what we call in the NP world is watchful waiting. Sometimes that's the best course to just see if the symptoms are going to continue, worsen, or even appear at all. These are all your considerations you want to just think about before you start ordering tests, okay? Again, and here's some more things. Are there tests available that are acceptable to patients and at a reasonable cost that detect the condition in an asymptomatic period? Okay, is the evidence of the condition sufficient to justify the cost of the screening? That's very important, because sometimes you'll order a test that you really think could be justified, and you have to be able to defend that as a nurse practitioner in case the insurance company tries to deny it, because you can always appeal it, but you want to have a sufficient evidence that it's actually appropriate and sufficiently justified to actually order this particular screening test. You want to obviously assess for barriers to the patient obtaining the screening test. Do they have access to that particular place they have to go? Are they actually able to get in and out of the facility to take the test? These are the kinds of things you want to consider. And number 8, just because there are national guidelines, it doesn't necessarily mean that the test, treatment, or medication will be covered. You always want to make sure this patient has the insurance that will cover these particular treatments or tests. Some of these things can be extremely expensive, and then the patient is stuck. So it has to be worth it. Okay, so here is the USPSTF guide to preventative services. So it's the United States Preventative Service Task Force. It's an organization, and they provide guidelines for primary preventive screening, which are widely followed. And you can look at this link and it'll give you all the recommendations and, for the particular age, depending on the patient and the risk factors that are involved. It's, definitely for primary prevention and screening exams. And this is really a good guide because it will also solidify what insurance covers. I mean, a lot of it goes based on this particular entity's guidelines. Okay.